Hello, this is Chadi Alraies, and this is CVI2018. With me is Dr. Joao Cavalcante. He is the Director of Structural Heart Imaging at Pittsburgh University. Welcome, Dr. Cavalcante.
Thank you, Chadi. It's a pleasure to be here.
Always. So you just spoke up to us now, a few minutes ago, about multimodality imaging for aortic valve stenosis pre-TAVR. And you touch on multiple images. And as an advanced multiple imaging professional, can you tell us about 2018 and how we can evaluate that?
Yeah, I think that's a great way to get started. Aortic stenosis has become a little bit more complicated than what we used to evaluate. And I think in large part because of this discrepancy between valve gradients and aortic valve severity. It's not infrequent that we face these patients with low gradient and with severe aortic stenosis. And the main question is, do they really have severe aortic stenosis? And I think, if we take a step back, what we have learned with the advanced imaging and what we presented today was the opportunity to learn better on how can we stratify these patients. How can we make sure using, for example, coronary, cardiac CT as a means to evaluate the amount of calcium that valve has. The more calcium, perhaps the more severe the aortic stenosis will be. And we know that now they are gender specific. Cutoffs for women cannot replicate it for men. But that's a good method that we can take the flow independence and say, this is significant aortic stenosis. That's still how we treat these patients. And I think, the calcium of the valve also has other implications as we have learned. For example, the amount of paravalvular leak, aortic rupture, pacemaker need. So there are certain nuances that we still in 2018 facing on. We know how to place these valves, but actually the scrutiny is higher, isn't it? We have to be even better than what we can deliver, particularly as we move into the lower risk patients where the bar is going to be quite high.
And you touch on a fact that really kind of intrigued me is how to predict pacemaker based on the calcification characteristic of the leaflets.
Yes.
Can you tell us about it?
Yeah, so this is an interesting paper that came out a couple years ago. And basically we know that, for example, the risk factors that patients brings in, for example, right bundle branch block. If you have right bundle, the likelihood of having complete is going to be higher. Yeah. We talked about the membranous septal length, but that's just one dimension. The other one that you mentioned is the distribution of calcium within the valve. And it turns out that actually that calcium that drapes down from the non-coronary cusp into the LVOT, that device landing zone, is an important area, not only for potentially rupture, but also from compression to the AV node. And the other one that we highlighted today was the distribution of calcium on the left coronary cusp. And it turns out that it's almost like, me and you pushing against you, the non-coronary cusp, I'm the left coronary cusp. It's going to be an arm wrestling. If the left coronary cusp has a lot of calcium too, that is not going to give in so much, and such is going to push into the non-coronary cusp. So in addition to right bundle branch block, the calcification of the left coronary cusp is important as well to be considered. And we can do this with CT with the right segmentation.
Nice. Yeah. How about MRI?
Yeah, so I think the MR role, it's extremely exciting because, it's not now moving away from the valve and understand the ventricular remodeling that these patients have. And it's a spectrum of disease. And, the long story short is that the more we look, the more we'll be able to find. There is a recent publication that I highlighted on my talk that was at the circulation this past week with a very large registry, more than 600 patients, looking at how much does scar, once detected by MRI, plays into the outcomes. Everybody receiving therapy, either SAVR or TAVR. It doubled the mortality. It tripled the cardiovascular mortality. And when we look at these patients, almost half of them had scar. And the predominant phase of scar was actually not ischemic scar, was actually non-ischemic scar. So what that implies to me is that are we intervening potentially a little bit too late? We're waiting for the ventricle to remodel, waiting for that ventricle to become fibrotic, and then at times the symptoms come, and then we're going to pull the trigger. Yeah. Could we use MR as a metric by which we can intervene and consider intervention a little bit early on? This is a lot of work that we are doing in collaboration with other investigators, but I think it's a way that we could potentially identify where's that sweet spot, not only for intervening early, but also for those when we intervene, the outcomes might not be as good as we anticipate, and we might be informing better decision making. One of the advances that MRI has allowed us to, and that I presented, was the ability to identify cardiac amyloidosis. So that is another important phenotype. It's not uncommon. about 16%, so 1 in 6 patients. And this overlap of two aging processes actually seem to carry a bad prognosis. We looked from the metric of mortality, but as important as mortality would be, potentially actually symptom improvement. They might not get the full benefit. They might still get some survival. We don't know what's the delta, but it's still a work in progress. I don't think at this point in time we should withhold treatment. I think if we have somebody that has, and particularly their octogenarians, males, low gradient, if you face and you evaluate and you identify amyloidosis, I think at this point we should inform the decision making. Hey, what is your expectation? What do you want us to do? At times they might say, I just wanted to go home.
Yeah.
But at times they say, why don't you embark on this? And I think having that discussion and shared decision making is key on how we evaluate and treat these patients.
So it sounds to me like MRI going to having two roles. Number one, for the low risk population, where you're going to screen for them for scarring, because probably even the hemodynamics and the flow is not severe enough.
Exactly.
But probably going to intervene fast. And also on the other extreme population who are older, to see if valve replacement will be helpful for them once the amyloidosis is established.
That's a great way to summarize.
Okay.
And I think we need to bring that new modality into the arena. I mean, as are we layering tests? Perhaps, but I think that's the opportunity where the stakes are high. Intervening on a $30,000 valve into somebody that might not have a good outlook of this, what are we doing here? It's not bringing futility, but I think better understanding of the pathology. And for those that we are still kind of waiting for symptoms to develop, when we could intervene early on before the scar develops.
Exactly. Well, it was great talking to you, Joao.
Likewise.
It's an amazing talk, amazing meeting, and please listen to his talk, also going to be on CVI YouTube channel and also on the website. This is Chadi Alraies from Colorado.
Thank you.